So many of us probably I have seen uh, in past 5 6 years, none of the Fourniers gangrene have been reconstructed here. So probably I can ask Dr. Pallavi, what do you do in a Fourniers gangrene? The scrotum is completely destroyed. Both the testes are hanging. What do you do?
Here today we take one case wherein in the lateral side
Okay. Okay. So if given an option to the patient, if you ask the patient if you want to keep your testes in the thigh or you want a new scrotum, obviously the patient will want to have a new scrotum. So we are going to tell you how it can be achieved in next 15-20 minutes. As usual, my presentation is going to be having all emotions, typical Bollywood style. So this is a very famous marble sculpture by Michelangelo, present in the France, Italy. So here you can see it indicates a lot of things like aesthetic perineum or aesthetic scrotum and penis, how it should be there, and if the patient had a Fourniers gangrene and if he was not reconstructed, then he would have covered something like this. He needs to cover like this and stand inside the museum. So why testis is very important? So it's very important because you have to have a next generation. For that you need to have a spermatogenesis. And another important thing about testis is production of testosterone, the hormone that gives masculinity, that gives a lot of courage, and many people have won war because of this testosterone. So if the person doesn't have a testis, then he can have a psychological effects like feeling of loss of consciousness, uneasiness. He can feel shame. He can have loss of confidence, depression, weakness, obesity, and he can feel less masculinity. So how big is the problem? So this was the image I had taken in my post-graduation days. So at any given point of time, we used to have 7 to 10 patients of Fourniers gangrene referred from general surgery and urology. That time we had continuously patients of Fourniers gangrene. Then I was dressing, so I made them stand and we took the photos. The funny part of this photo was, once I took the photos, then the patient discussed among themselves that how much amount of kin a person A had, how much amount of loss of kin a patient B had. So they were discussing among themselves. So Fourniers gangrene, it's a necrotizing fasciitis of genital and perineal tissues. It was coined by Jane Alfred Fournier in 1883. It's an abrupt onset of rotal pain swelling in young healthy men, and it is known to have a rapid progression to gangrene of skin and subcutaneous tissue. Most of the times it's idiopathic. There is no particular cause for this. Etiology, as most of you know, that 95% of the cases urogenital, like urethral strictures, periurethral abscess, epididymoorchitis, phimosis, circumcision, instrumentation, catheterization. So it's very important. Probably urologists will know that the most sterile, one of the sterile procedures is catheterization, which is most neglected. Next, colorectal diseases like perirectal abscess, hemorrhoectomy, colorectal cancers, diverticulitis. Comorbid problems, more so is seen in diabetes mellitus, alcoholism, smoking, immunocompromised conditions. Most of the times the microbiology here, they have a synergistic polymicrobial infections, aerobic like gram positive streptococcus, staphylococcus, gram negative like Escherichia coli, Klebsiella and Proteus, and anaerobic organisms, bacteroids, Clostridium. Pathogenesis, most of you know that it's organisms, they spread among the planes, they enter into the Colles fascia, then from there they can go into perineum, they can come into scrotum or penis, they can enter into the abdominal wall. From there, if there is a microthrombi, the arterioles, they get microthrombus. which leads to the gangrene of the skin and the soft tissue. So the clinical features most of the times is a sudden onset of pain, fever and systemic toxicity. Cellulitis is present, cryptus is present, eschars are seen, foul smelling, gangrene of the skin, subcutaneous tissue, and most of the times testes are spared because it has an independent blood supply from the abdomen, testicular artery, and the tunica albuginea, which is a very strong covering of the testis, it usually prevents the spread of the infection to the testes. So early diagnosis is by marked systemic toxicity that is out of proportion of local signs. So that's how we diagnose the Fourniers gangrene. So what is the treatment? It's a very important that you people frequently see this Fourniers gangrene, and the very important first thing is fluid resuscitation. The usually patients are in shock and they need a extensive fluid resuscitation with a triple antibiotic therapy. Most of the times ampicillin with sulbactam, or third generation cephalosporins with the gentamicin, clindamycin or metronidazole. Depending on the culture, again you can change the antibiotic. Monitoring of gangrenous patches is very important. It needs an aggressive serial debridements. Debride till you have a very good fresh bleeding. Urinary diversions in case of periurethral suprapubic catheterization may be required in some patients. And when the perianal regions are involved, fecal diversions like proximal colostomy is needed. Followed by that, reconstructive procedures. So for us, whenever we don't get a direct Fourniers gangrene, it's always most of the times referred from general surgery or urology after initial debridements. And choice of reconstructions obviously depends upon the size, location and severity of defects, availability of the local tissue factors. So the most common age where this Fourniers gangrene is seen is in between 31 to 40 years, followed by 41 to 50 years. Other peak is 71 to 80 years when the patients are usually immunocompromised. Most common gender is obviously male, but we have even seen in females. And time interval of onset of symptoms to presentation, usually most commonly when we see patients are in between 2 to 15 days, and the last debridement performed to first reconstructive procedure is 11 to 35 days. Most of the times length of hospital stay used to be 19 to 53 days, but nowadays we have cut down to almost 8 to 10 days. So the most common presenting symptom was pain, followed by fever, scrotal swelling and gangrene. Lesions, most common again scrotum, followed by penis, scrotum with perineum. Sometimes it can involve vulva, perineum, scrotum, groin and abdomen. So these are the few of the images where the entire scrotum is gone and testis is exposed. This is a Fourniers gangrene of the penis, Fourniers gangrene involving the perineum, Fourniers gangrene involving the vulva and the perineum, Fourniers gangrene involving the groin along with scrotum, and another female patient with the involvement of groin and lower abdomen. So the most common predisposing factors what we saw among all the patients were, many of them they were alcoholic, and equal number of patients had a smoking as a habit, and 2-3 patients they had a diabetes, and some patients didn't have any predisposing medical factors, identifiable factors. Bacteriology, when we sent a culture sensitivity, most common organism was Staph aureus, followed by E. coli, Klebsiella, Pseudomonas, Protease. So ancillary procedures that were performed was in few patients diverting colostomy, and few patients suprapubic cystostomy was done. So what is the treatment for these kind of wounds? These kind of wounds, when the testes are exposed, I never personally suggest an orchidectomy or placement of testes into the thighs. The testis plays a very important role in spermatogenesis. Because of that, the temperature of the testicular region is lesser than the body temperature. That is the reason why the scrotum's temperature is 2 to 3 degrees lesser than the body temperature, and that's how it has to be done. The moment you keep the testis into the medial thigh, the temperature becomes same as the body temperature, and the spermatogenesis and the production of testosterone hampers. That can lead to various the kind of symptoms I have told that can happen. So what all reconstructive procedures we did in our patients, where we did a secondary suturing in few of the patients, split thickness skin graft, that was the most common reconstructive procedure, tensor lata flap, medial thigh flap, medial thigh viva advancement, bilateral supremedial thigh flap. These were the most common procedures. Now I am going to show you a few of the slides with this patient had a 1/3 of the scrotum that was gone. So up to 1/3, in fact even half, we can do a secondary suture and close the scrotum primarily, and this heals very well, and the temperature is maintained, function is maintained. Another patient with a scrotal defect, secondary suturing was done. Another patient with a Fourniers gangrene, very well granulated. Like if the granulation is very good, you can just apply a split thickness skin graft. One of the most important aspect of the dartus muscle or the tunica albuginea, once it granulates, the take of the skin graft is excellent. Like it almost feels the normal. The sensation is almost normal. So here we did a split thickness skin graft. Another patient with the Fourniers gangrene, very well granulated, like it granulates really very well. In fact, you can apply 2 or 3 settings of WAC even in case of a hanging split testis. You will get a granulation tissue something like this, and apply a split thickness skin graft. Another patient with the Fourniers gangrene on the penis, split thickness skin graft was done, achieving an almost near normal appearance. Another patient with a Fourniers gangrene of the penis, applying a split thickness skin graft, near normal appearance. This patient had a involvement of the groin along with the scrotum. So we did a tensor fascial lata flap taken from the left thigh, and after reconstruction, it appeared something like this. Another patient, female patient with the involvement of groin, we did a tensor fascial lata flap, and this was the final appearance. In few of the patients where the perineum is involved, in those patients, ideally it is best to use a medial thigh flap, because those areas the patient needs to sit. Having a frequent friction can cause a trauma to the split thickness skin graft. In those patients, we did a medial thigh flap, having almost near normal appearance and excellent healing. So another patient with a unilateral medial thigh flap, where the scrotum was exposed, and we did a medial thigh flap, and wound was covered. This patient, we didn't have any local scrotal skin, so we did a bilateral superior thigh flaps. These are the bilaterally, we have raised the flaps, created a neorectum, and this is a final appearance. The scar goes inside the crease, so scar is also not seen. Aesthetically very wonderful, and the patient, even though inferior than the skin graft, but better than keeping it in the thigh or doing an orchidectomy. Another patient with this is the same patient after 3 months of follow-up, almost near normal, excellently looking, cosmetically better looking scrotum. Another same patient having a 6-month follow-up. This is one of the, like, even though it's not mentioned, but one of the way of healing is also by secondary intention, even though we don't suggest it. But this patient had a extensive perineal Fourniers gangrene with a debridement. The patient was not ready for surgery, but it healed secondarily with a lot of scarring, and this can be one of the method of treatment. So coming to discussion, Fourniers gangrene is a very rare condition. It's not a rare condition actually. It's a, and there has to be a high index of suspicion for early diagnosis for a better outcome. Early treatment consists of hemodynamic stabilization, broad spectrum and IV antibiotics, monitoring the patient for appearance of gangrenous patches, aggressive serial debridements, followed by reconstructions. Reconstruction of scrotum, phallus and other associated area is very important for cosmetic reasons, functional and psychological issues. And if the scrotal reconstruction for that less than 50% is a skin loss, you can consider secondary suturing. And if the skin loss is more than 50%, if the tunica vaginalis is intact, you can consider using a split thickness skin graft, meshed non-expanded skin graft, along with the bolster dressing. These are very important, bolster dressings. If the tunica vaginalis is breached, then you need a local flap. So penile reconstructions, most of the times it's a thick split thickness skin graft. It has to be a non-meshed. Bolster dressings are needed, and avoid post-op erections by giving sedatives for a few days. Perineum reconstructions need a local faciocutaneous flaps. So coming to conclusion, Fourniers gangrene is not a rare condition. It needs a high index of suspicion for early diagnosis. Aggressive serial debridement with IV antibiotics are needed. Reconstructive surgery makes the patient's early return to normal life very much possible. So I want to share one of the very funny thing about where I read. We had Dr. Shashank sir speaking about headache and all. So there was one, fictional one. Vikesh was a patient of 45 years old. He had a headache since 20 years. So he was fed up with the headache, and finally he decided to see a doctor. The doctor said that he had a very peculiar condition where his testicles are pressing on the spine and causing the one big lot of headache. He underwent MRI scan, he underwent CT scan, he underwent a lot of investigations, and the surgeon said that the only way to relieve the pressure is remove the testicles that is causing the pressure on his spine. So Vikesh had no other choice, and he has to go below the knife, remove the testicles. So surgery costed him around 1 lakh in a big corporate setup. Finally, after discharge, he felt something important was missing from himself, and he went on a street, thought that it's a rejoice that after 20 years of headache, I don't have any headache, so I can buy some new clothes. He went to Raymond shop. The tailor saw him and said, the new suit size you fit in size is 44. Then Vikesh asked, how you know that? The tailor said that I have an experience of 50 years and I know it very well. I can see the person and I can tell what is the size of the. So the next day he said he saw the Vikesh and said the pant size is 36. Then Vikesh said, yes, absolutely correct. How do you know this? Then the tailor said, my experience of 50 years. Then he said, you are taking everything. Let's buy you an innerwear. Then the tailor said, you need a 36 inches innerwear. Vikesh said, you are wrong. Then the tailor said, I cannot be wrong. No, Vikesh said, I use 34. Then the tailor said, if you use 34 innerwear, the underwear causes the pressure on your testicles, that presses on your spine, that causes headache headache. Then Vikesh thought, all these days, 20 years, he was using a wrong innerwear. That led to a castration, that led to a cost of 1 lakh. So before doing any major surgery or before doing anything, probably you need to think what best can be done. So this was about my reconstructive approach towards Fourniers gangrene. Thank you.